Dr. Bizant's a board-certified neurologist with Norton Neuroscience Institute, where he focuses on neuromuscular neurology and electrodiagnostic medicine and EMG. Additionally, he is the director of the Amyotrophic Lateral Sclerosis Clinic. He received his medical degree from the University of Nebraska College of Medicine in Omaha. He then completed his residency in neurology and fellowship in clinical neurophysiology and electromyography at Indiana University School of Medicine in Indianapolis. Dr. Bizant's a member of the American Academy of Neurology and the American Association of Neuromuscular and Electrodiagnostic Medicine. So Dr. Bizant, thank you and welcome.
Thanks a lot. Let me try to get my stuff all set up here. Give me just a second. All right, I think I'm. All right, I think that's good. So thanks for having me. Again, as mentioned, my focus is neuromuscular neurology. So while picking a topic, I try to think about what would be most useful to our primary care providers. And of the things I see in clinic, I think that peripheral polyneuropathy is probably the issue with the greatest overlap. And peripheral polyneuropathy can be tricky sometimes because the differential for causes is pretty broad. So my main goal today is to provide you with a practical approach to peripheral polyneuropathy that you can implement in clinic and hopefully in a way that is time efficient. So give me a second here. There we go. All right, so no disclosures today. Okay, so just a quick note here that there's lots of different neuropathies, with neuropathy being a generic term that just means nerve damage, and neuropathic diseases can present in a lot of different ways. So in neurology, we like to look at the patterns of nerve involvement to try to narrow down the possible causes of neuropathy, and we can divide them up by what types of nerves are involved. So the questions we ask are they symmetric, are they asymmetric, distal versus proximal, and how quickly did they develop? So we're going to focus on the type of polyneuropathy everyone here is probably most familiar with. That's the distal symmetric polyneuropathy. So this is the pattern of polyneuropathy we would see when one of our diabetic patients comes in and says their feet are numb, for instance. So in terms of a plan today, what we're going to do is discuss a standard approach to evaluating our patients with peripheral polyneuropathy. And again, hopefully in a way that can be done in an efficient manner, because I know we're all busy. Then we're going to hit on mechanisms of neuropathic pain and the first tier neuropathic pain medications we use to treat them. And if we have time, we'll hit on just a few interesting notes about diabetic peripheral polyneuropathy. Okay, so let's start off by talking about a standard approach to evaluating our patients with peripheral polyneuropathy. And I should make a caveat here that this isn't an attempt to give you a comprehensive list of things that can cause peripheral polyneuropathy. But I think that if you can follow these steps, it's a pretty thorough approach, and it's pretty much what I do for initial polyneuropathy evaluations for folks that I see in clinic. Okay, so whenever someone comes in with a peripheral polyneuropathy, I basically have three goals. All right, so I want to confirm I'm dealing with a distal symmetric polyneuropathy, and you can verify diagnosis with EMG and nerve conduction studies. But generally you can confirm this with history and exam alone. The second thing I'm going to want to do is attempt to identify an etiology for that distal symmetric polyneuropathy. And the third thing that I'm going to want to do with that information is begin treatment. And that's going to basically have two prongs. So the first is treating the cause, and that's assuming you're able to identify a cause and that cause has a treatment. And then the second thing is treat the symptoms. And neuropathic pain is generally going to be the dominant symptom that people are going to complain of. So in terms of confirming the presence of a distal symmetric polyneuropathy, more often than not, this process is going to be pretty straightforward. And you can often get what you need by history and exam alone to confirm the diagnosis. Now, when we think about various peripheral polyneuropathies, we tend to focus on three different types of nerves that could be involved. So there's sensory nerves, there's motor nerves, and then there's nerves supplying the autonomic nervous system. So in our typical distal symmetric polyneuropathies, you could certainly see autonomic complaints like orthostatic intolerance, sweating changes, GI and GU complaints, in addition to some motor complaints, though these tend to be secondary complaints. And usually the domain that's most effective is going to be the sensory domain. So patients are generally going to endorse numbness, and we refer to this as a negative symptom, in addition to positive phenomena like paresthesias, which is tingling, or pain. Now, the pattern of these complaints should be distal, and they should be relatively symmetric. And the tempo of onset should generally be slow and gradually progressive. So these length-dependent processes will affect the longer nerves first, followed by shorter segments. So the pattern that we would tend to see is going to be, initial involvement in the toes, then the feet, then it rises up to the knees, and at that point, a lot of times you would tend to see, the hands become involved. So examination. So generally, after obtaining a bit of history, I'm going to have a pretty good suspicion that what we're dealing with is a distal symmetric polyneuropathy, and your typical exam findings are basically going to mirror those typical symptoms. So I like to make sure that we're paying attention to examining sensory nerves and motor nerves, and if there are symptoms that would suggest autonomic involvement, and generally that's going to be cardiac in nature. So a lot of times what they're going to complain about is orthostatic intolerance. You can easily do some bedside autonomic testing with orthostatic vital signs. So in terms of the sensory examination, there are several things you can do, but to keep it simple, you could just check vibration with a tuning fork, over a digit of the hand and a digit of the foot, in addition to a pinprick examination, for which you can pretty much use any pointed object. A broken tongue depressor would do the trick. And what you'd expect to see is going to be a length-dependent process where, vibration is considered stronger in the upper extremity when you compare it to the lower extremity. And the pinprick sensation is generally, pretty uniformly reduced below a certain point in the lower extremities, and if severe, in the hands. And we call that a stocking and glove distribution. So the motor findings would tend to be pretty mild. The vast majority of the time, strength testing in these distal symmetric polyneuropathies is going to show normal strength throughout. And more often than not, the clue for me that there's motor involvement is going to be some reduced bulk of musculature of the feet. They basically just look a bit thin. In terms of reflexes are often lost at the Achilles, but tend to remain intact, in the upper extremities. It's a length-dependent process. And in those patients who are describing some of those autonomic symptoms, again, cardiac symptoms being the most prominent, usually with orthostatic intolerance, I'll try to check orthostatic vital signs. And the way I like to do this is by checking blood pressure and pulse, after they've been supine for several minutes, and then I'll stand them up immediately and recheck at 1 and 3 minutes. So the criteria for orthostatic hypotension would be a drop in systolic blood pressure of 20 points and diastolic blood pressure drop of 10 points. So, putting it together, in these folks who have typical historical features and typical exam findings, which we talked about previously, you can generally be pretty confident that you're dealing with a typical distal symmetric polyneuropathy. A few red flags to watch for that might prompt an early referral to neurology are going to be things like rapidly progressive neuropathies, those that have significant motor involvement or significant asymmetry, as these conditions, or these patterns, I should say, are more likely to have an identifiable etiology for which early treatment might be able to lead to improvement and prevent worsening. So one question that tends to pop up quite a bit is whether all patients for whom you're considering a polyneuropathy are going to require an EMG with nerve conduction studies. So, the answer is that not everyone requires an EMG. The question really is how do you decide? What I like to do is obtain an EMG, or excuse me, I tend not to obtain an EMG when the signs and the symptoms are mild, the exam is consistent with a distal symmetric polyneuropathy, especially when I have a probable etiology, because the chances that the results are going to change my impression or management are admittedly pretty small. So I tend to advocate for an EMG when I'm not entirely sure we're dealing with a polyneuropathy and I want to confirm this, when there are some atypical features that we discussed previously, And specifically, that's going to be prominent motor symptoms, asymmetry, a non-length dependent pattern of the symptoms, and when the onset or progression is acute or subacute. All right, so at this point, by this slide, we're going to assume that based on the history and exam and plus minus an EMG, we've confirmed that the patient has that pattern of a distal symmetric polyneuropathy. And what we want to do is turn our attention to focusing on an etiology for the polyneuropathy. So the rationale here is that if we can identify a cause, possibly we can treat that cause and prevent progression. So now one of the frustrating things about peripheral polyneuropathy is that even following a really thorough workup, you'll be left without an obvious cause in about 20 to 30% of cases. This would tend to be more common in older adult patients. So for me, the process of identifying an etiology basically includes the tasks seen here. I like to look at the past medical history for conditions that can be associated with polyneuropathy. List for possibly offending medications. I screen for alcohol overuse. And then I'm going to supplement the history with some labs, including kind of two buckets. So there's a few labs that we would check for all patients because we know they're higher yield, in addition to selected labs based on risk factors. So the first thing here that I do again is look at their past medical history. So there's enough associated with polyneuropathy. So this list isn't an attempt to be comprehensive by any means, but in terms of the higher yield medical conditions that should pique your interest, I think these are pretty good. The first is going to be diabetes mellitus, which is by far the most common cause of a distal symmetric polyneuropathy. I like to look for end-stage renal disease, malignancy, noting that some malignancies can cause polyneuropathy, but more commonly the chemotherapy we use to treat it is the offender. I like to look for connective tissue disorders, gastrointestinal surgery, and inflammatory bowel syndrome or disease because they're common risk factors for nutritional deficiencies. In addition to things like HIV, which can cause polyneuropathy, and some of the HIV can as well. In terms of the medication list, I like to look at this and see if there's any relevant medical history as well for possible agents in the past. And if I think there may have been exposure as well. So again, this list isn't an attempt to be exhaustive, but these would be, so chemotherapeutic agents, probably the most commonly associated meds, at least in my experience. The big classes are going to be taxanes, platinum-based agents, vinca alkaloids, and proteasome inhibitors like bortezomib. Other medications would include amiodarone, phenytoin, HIV drugs, in addition to things like isoniazid and metronidazole, though, honestly, more of the time, those aren't terribly relevant. Amongst the items, again, on this list that I think are really important, screening for alcohol use is probably right up there because it's the second most common cause of polyneuropathy, and continued overuse is only going to serve to worsen that polyneuropathy. And I've certainly seen plenty of people with alcoholic polyneuropathies that are pretty severe. So just a really quick note here that if you suspect a history of alcohol overuse, go ahead and supplement them with thiamine, provide some counseling, because certainly you can ward off additional problems that they may experience down the road. So the issue of which labs to send in the evaluation of polyneuropathy comes up quite a bit. And as I mentioned earlier, this can be a bit tricky because the possible etiologies for a distal symmetric polyneuropathy are really numerous. And clinically, these different causes of neuropathy look the same. So what I think is a reasonable approach is this. There are some labs that are going to be recognized as highest yield and should probably be sent on everyone. And there are some additional labs which are generally lower yield that we should send if a patient has relevant historical risk factors, which we can determine based on a few questions and some clinical observations. So these labs are determined to be, these labs here are determined to be a pretty good idea to send on everyone. And this comes from an AAN practice parameter. So these labs that are going to be appropriate for everybody is going to be a glucose assessment, a B12 assay, which should include a methylmalonic acid, which should help determine if folks in that 200 to 400 borderline range, are truly deficient. In addition to an SPEP and an immunofixation electrophoresis to identify neuropathies associated with monoclonal gammopathy. Now, in terms of the labs that we should send based on risk factors, the higher yield group, the higher yield of this group falls into, I think, just a few main categories. So these, I believe, are the general categories of other things that tend to be higher yield in an initial workup of polyneuropathy. So typically, while I'm obtaining history, I have a pretty good sense already that we're dealing with a peripheral polyneuropathy. So after getting a history of the symptoms, I'll tend to ask a few questions to assess, whether I think further workup into these categories is going to be required. So nutritional deficiencies, there are several nutritional deficiencies that can lead to peripheral polyneuropathies, and these are listed on the right here. So I'll always be sure to ask about weight loss, dietary restrictions, GI surgeries like bowel resection and gastric bypass, or any symptoms like chronic diarrhea that suggest a possibility of malabsorption. If these risk factors are present, I'll generally send for a B1, B6, B12 with methylmalonic acid, a copper and vitamin E level, and if they're deficient, we'll supplement those appropriately. So the next bucket is connective tissue disorders. So I also ask screening questions for possible connective tissue disorders. Most connective tissue disorders do have the ability to produce a peripheral polyneuropathy as a part of what they do. Whenever I show a slide like this on rheumatologic conditions, I always feel like I can hear a collective groan from rheumatologists, but generally what I'm going to do is ask about whether they've experienced rashes, inflammatory joint changes, sicca symptoms, and then with a question of possible vasculitis and such, I'll be sure to look at labs and history to see if they have renal insufficiency, pulmonary issues as clues to underlying autoimmune disorders. If the answer is yes, I'll often do a limited screen that's admittedly less sophisticated than a rheumatologist might perform, but is probably going to include things like inflammatory markers, an ANA cascade, and a rheumatoid factor. Now, I've included a vasculitis workup here in an attempt to be thorough, but in general, a vascular neuropathy is going to present more often than not with a stepwise progressive and asymmetric pattern. And we refer to this pattern as a mononeuropathy multiplex, but sometimes it can present with a confluent distal symmetric pattern from the get-go or as individual nerves are picked off over time. So if I have a suspicion for vasculitis based on the presence of additional systemic features, this group of labs here is generally what I would send to work that up a bit further. And I generally want to refer on to rheumatology. All right, so toxic exposures. So to be honest, aside from toxic exposures by way of medications and alcohol, I tend not to get a lot of hits from this particular category. Heavy metal panels are pretty frequently sent, but rarely useful. And so I tend to send these along infrequently. The one thing on this list here that might pop up a bit more frequently would actually be B6 toxicity. It's a component of B complex vitamins, and you can get it, of course, as an individual supplement. And B6 is one of those unusual vitamins where it can lead to neuropathy when deficient, but also due to toxicity when it's taken in high amounts. So if a person is taking a B6 supplement or a B complex vitamin, I'll generally send these as well. So I'll always ask about family history of polyneuropathy, as there are certainly many genetic causes of polyneuropathy. Polyneuropathy, in grandma with onset when she was 80 is probably not as relevant than if you had a family member with an otherwise unexplained polyneuropathy, which developed earlier in life. So if you have a suspicion for a heritable neuropathy, this is one where it probably makes sense to simply send along that patient to neurology for evaluation, as that can get a little complicated. So, that set of slides, basically concludes the initial workup that I would routinely perform in evaluating those patients. And obviously, if the history or workup demonstrated an etiology, I'd go ahead and start relevant treatment of the underlying cause or refer along to the appropriate resource. But the second component of this is treating the peripheral polyneuropathy, or of treating peripheral polyneuropathy is really symptom management. So more often than not, this is going to involve management of neuropathic pain. So what I'd like to do is spend a few minutes talking about neuropathic pain, in addition to neuropathic pain management, because when people walk in the door, a lot of times neuropathic pain management is really what they're looking for. So people with peripheral polyneuropathy tend to experience a few things. So they tend to experience spontaneous, unprovoked pain that's generally described as burning, sharp, or electric in nature, possibly with paresthesia or tingling. And the painful stimuli can be produced by an exaggerated pain response, which we refer to as hyperalgesia. But it could also be a benign stimuli, something like sheets touching the feet, that can produce pain. We would call that process of benign stimuli leading to pain allodynia. So this is important, obviously, an important topic, I should say, because pain can lower quality of life. It can impair a person's ability to sleep, and it's commonly associated with anxiety and depression. So effective treatment can go a long way to improving patients' quality of life. All right, so this slide is basically a cursory overview of the somatosensory pathway that I wanted to include in order to highlight a few relevant points for neuropathic pain. So after a stimulus is applied, here in the foot, one of a number of specific sensory receptors is going to detect that stimulus and initiate an action potential that's going to propagate up the first order neuron. And remember that sodium channels play an important role in depolarization of those ion channels. They're not the only channel, but they play an important role, as we'll see here in a little bit. And when that signal enters the spinal cord, it's going to synapse in the dorsal horn. And at those presynaptic terminals, voltage-gated calcium channels are going to activate. And that's going to lead to an influx of calcium and thereafter neurotransmitter release. And the relevant point here is that alpha-2 delta subunits are going to promote voltage-gated calcium channel activity. From there, the signal is going to travel up second-order neuron to a contralateral thalamus and then on to the somatosensory cortex. And importantly here, we also have pathways that are going to go from the brain and brainstem and descend down the spinal cord to inhibit some of these sensory stimuli to modulate or inhibit pain. And this is mediated by norepinephrine. So in the setting of peripheral polyneuropathy, we see several problems arise here that are going to end up promoting neuropathic pain. So we see changes in sodium channel function and expression, and that's going to lead to or promote ectopic firing. We see increased expression of alpha-2 delta subunits, which make it more likely that stimuli are going to lead to neurotransmitter release in that dorsal horn. And we also see dysregulation of the descending inhibition pathway. And the net result of all of these changes is going to be to strengthen the excitatory pain pathways here. So, with that, the question is, how do we treat neuropathic pain? So there's lots of different medications that can be utilized for neuropathic pain, and different guidelines might cite different agents, but there are 3 classes of medications that are generally agreed upon as being the most effective. And I think if you have fluency with these classes, you're going to be in pretty good shape. So these 3 classes are going to be the gabapentinoids, the serotonin norepinephrine reuptake inhibitors, and the tricyclic class antidepressants. So let's go ahead and go through these agents, or these classes, I should say, one by one. So we'll start with gabapentinoids. So despite their name, these actually don't bind to GABA receptors. The mechanism of action for the gabapentinoids is going to be binding to alpha-2 delta ligands or subunits that we talked about a little earlier. And that's going to reduce the transportation of voltage-gated calcium channels to the neuronal membrane. And in so doing, this can block the release of excitatory neurotransmitters. So there are 2 gabapentinoids, gabapentin and pregabalin. Side effects are going to be the same in that they can produce sedation, edema, and weight gain. And in renal insufficiency, we're going to want to titrate downward on the dose. So the dosing here is different, with pregabalin being more potent. So I generally start gabapentin in the ballpark of 100 to 300 milligrams 3 times daily. Then I'll gradually increase as needed up to a maximum of 1,200 milligrams 3 times daily. Pregabalin, I usually start around 50 milligrams 3 times daily, and I'm going to increase that up to 200 milligrams 3 times daily. And with any agent, I'm going to use the lowest effective dose. Here, pregabalin has the advantage that it can be used in a twice daily fashion, whereas gabapentin really is best 3 times daily. So moving on to the SNRIs. So these are going to inhibit reuptake of norepinephrine and enhance the effect of that descending inhibitory pain pathway, which is going to terminate in the dorsal horn. There are more SNRIs than I've listed here, though these tend to be the ones that we use for neuropathic pain management, duloxetine and venlafaxine. Side effects, again, both can cause nausea, hyperhidrosis, hypertension, low libido, and you do need to pay attention to the presence of other medications with serotonergic activity, given the risk of serotonin syndrome. In terms of dosing, for duloxetine, I would generally start at 30 to 60 milligrams daily. Generally 60 milligrams per day is going to be sufficient, though you can increase that up to 60 milligrams twice daily. And then for venlafaxine, the starting dose would be 37.5 to 75 milligrams per day. And then I titrate that up to a total of 225 milligrams per day. With the IR formulation, I would generally split into twice daily or 3 times daily dosing if there was a dose above 37.5 milligrams per day. All right, so the tricyclics. So like the SNRIs, the tricyclics are going to inhibit norepinephrine reuptake, and they're going to increase the effect of the descending inhibition pathway and also block sodium channels, which would block those ectopic discharges out in the peripheral nerves. So again, like with the SNRIs, there's more tricyclics than listed here, but amitriptyline and nortriptyline are the ones used most frequently for neuropathic pain management. The side effects in this class tend to be a bit more notable than in the other classes we've talked about. Of the two, it's generally felt that nortriptyline is probably better tolerated. So side effects are essentially anticholinergic, at least predominantly. And if you have other QT prolonging drugs or a concern with cardiac disease, it's probably a good idea to obtain an EKG at onset with titration. Also, bear in mind that this medication, if it's ingested at moderately high doses, it can lead to cardiac arrhythmia. So if you have a concern that you have a patient who may be susceptible to self-harm, it might be reasonable to avoid this one. We tend to use lower doses than used for mood disorder. These come in different sizes, but generally the starting dose would be around 10 to 25 milligrams, titrate up to around 100 milligrams. And I would administer these at night because of the potential for somnolence. So second or third tier medications, again, there's numerous second and third tier treatments you can utilize. A lot of these have limited data for efficacy, but can still be worth trying. So I've just listed numerous here, but for the sake of time, we're going to go ahead and avoid going into these in detail. All right, so just a few principles of pain management or neuropathic pain management, I should say. I like to keep in mind, in terms of managing the medications we've talked about, that we have a limited number of neuropathic pain medications that are truly effective. So I think it's important that we make sure that we give neuropathic pain meds an adequate trial before calling a medication failure. So for me, an adequate trial is generally going to mean using an adequate dose over an adequate period of time. So I would generally titrate as needed up to the maximum dose, again, as long as it's tolerated, and make sure we use it for 6 to 8 weeks. And if at that point it's not effective, I would go ahead and call that a treatment failure and then wean. So some sources would advocate for using 2 of the main medications in each class before going to going to like a second or third line medication, but you wouldn't be obligated to do that. And to avoid polypharmacy, I always try to identify medical comorbidities that are also treatable with those neuropathic pain medications in an effort to limit the total medication burden. All right, so that by and large is going to cover the initial approach to evaluation and management of distal symmetric polyneuropathy. So I've got a few minutes here, so we'll talk a little bit about a couple points on diabetic polyneuropathy, as this is going to be the most common cause of a distal symmetric polyneuropathy that someone working in primary care is going to run into. And what I want to do is focus on some ways in which type 1 and type 2 diabetes are different, which does have some bearing on how we would approach these. So we tend to see diabetic neuropathy occur earlier after diagnosis in type 2. So in type 1 diabetes, the prevalence is about 20% at 20 years. And in type 2, it's about 50% at 10 years, with about 10 to 15% already affected at the time of diagnosis. Now, both type 1 and type 2 diabetes are characterized by abnormally elevated blood sugars. So you might think that glucose control would be similarly effective in preventing diabetic neuropathy, though that turns out not to be the case. So in type 1 diabetes, glycemic control is really pretty good at preventing the development of peripheral polyneuropathy. With intensive glucose control, that would lead to a 69% risk reduction, roughly. But in type 2, it's really not terribly effective, with most studies showing a small or even an absent benefit. I think I've got time here. So this slide fleshes out this information just a little bit more by taking a look at just a couple of specific large trials that looked into this, basically comparing intensive versus conventional glucose control. Bear in mind that the patient populations here are a little bit different. So the ACCORD trial with type 2 patients were older and had diabetes for longer than the DCCT trial that had type 1 patients who on average were younger. So it clouds comparisons a little bit, but the trends are basically what you'd see across studies. So the DCCT trial was a large study published in the early 90s, looking at various health outcomes, one of which was polyneuropathy, in subjects who are assigned to both intensive and conventional management. So this will give you a sense of the preventative benefits of glucose control on the development of peripheral polyneuropathy. So without going into too much detail, the standard therapy group basically received a regimen of 2 insulin injections per day, whereas the intensive group had 3 or more injections per day versus an insulin pump. There were several indices or criteria they were looking at to adjust the administration, but basically the A1C goal in that intensive group was going to be below 6.05. So I've included a little graph here that shows how effective they were at achieving this goal, just so you can kind of see the differences between the groups. So you can see an average A1C over the duration of the study. And in the intensive control group, that A1C was generally right around 7, and in the conventional group, around 9. So the relative risk reduction of this intervention turned out to be pretty significant. About 10% of subjects in that standard group developed polyneuropathy at 5 years, but only about 3% in that intensive control group developed neuropathy. The ACCORD trial was similar in that it looked at various health outcomes, which again included polyneuropathy, this time in type 2 diabetics, managed again with intensive versus standard therapy. The goal here was going to be an A1C below 6 in that intensive group and between 7 to 8 in that standard group. And so it's worth pointing out here that in the midst of the study, they actually ended up stopping the intensive therapy group as there was an increase in all-cause mortality. At the end of the period, at the end of that intensive versus conventional period, we see that the average A1C value in the groups were close to those targets. So 6.3% in the intensive group and 7.6% in the standard group. So in terms of the development of polyneuropathy, there's actually several indicators they use, or several different assessment tools they use to identify polyneuropathy. But overall, if you look at those in general, the risk reduction was pretty modest. So in the ballpark of 5 to 12%. So the question is, well, why is there that difference between type 1 and type 2 diabetes in the development of polyneuropathy and the lack of, a robust response to glucose control in type 2? Over time, there's been increasing recognition that in particular with type 2 diabetes, there's a contribution from the metabolic syndrome. So it isn't just the blood sugars that are causing that problem here. So I've listed just a couple of examples of this, noting how obesity and dyslipidemia can contribute to peripheral nerve injury. So the moral of the story here is that if we just treat the sugars, we're probably missing some important treatment targets. So recognizing the differences there in the pathophysiology between type 1 and 2 diabetes, the recommendations on management here do differ a bit. So in type 1 diabetes, the focus is on type glucose control, whereas in type 2, it's acknowledged that lifestyle interventions play an important role. In terms of what kind of interventions work here, so there are studies in prediabetes, for instance, which show that diet changes with a modest weight loss and exercise with a goal of working out up to 150 minutes per week, basically at an intensity at which it starts to become difficult to carry on like a casual conversation, can promote regeneration of small nerve fibers and showed a trend towards improved pain control. So generally, that's kind of what I'll tell people in terms of lifestyle modifications in this particular set of conditions. So I'm just going to skip that. I know I'm short on time here. Neuropathic pain management is essentially the same as that we discussed earlier. And just a note here before I run out of time that diabetic foot care is pretty important. So with loss of that protective sensation, there's going to be an increased risk of foot ulcers and ultimately amputation. So foot care is important. Encourage patients to examine their feet daily, wear shoes and change their shoes yearly, and keep those feet dry. Just a quick note, because I know a lot of the folks logged in are probably in primary care. There's a pretty good paper just going over a 3-minute foot exam that includes some counseling for diabetes, which is a pretty good read with practical information. So I should have a reference at the end of this talk if you want to look at that. It might be helpful in day-to-day practice. So that's pretty much it. If anybody has any questions.
Yeah, thank you, Dr. Bazant. I think we have time for one question, and I'll paraphrase it a bit. There are clinics opening up in Louisville and Lexington that claim to be able to reverse peripheral neuropathy through the use of stem cells. Any thoughts on that? Is there any evidence for their efficacy?
No, certainly not that I'm aware of. I think that I've certainly seen a lot of the stem cell kind of local groups proposing it for a lot of things. I've seen some of my patients in the ALS clinic go for that as well. But no, that's not something that I'd be recommending for any of my patients with actually anything that I'm seeing right now, but certainly not distal symmetric polyneuropathy.
Fair enough. Thank you.